In this video, we wish to show our modified technique about the laparoscopic thermoablation for patients with problematic hepatocellular carcinoma. We performed a selective intrahepatic vascular occlusion in order to obtain an increased rate of total necrosis and a reduced rate of local recurrences, controlling this effect with indocyanine green imaging and laparoscopic contrast enhancement ultrasound. We decided to treat an 80 years age patient with severe comorbidities, previous operated for peptic ulcer. He has been already treated for hepatocellular carcinoma with a percutaneous radiofrequency ablation. At a CT scan, he showed a new nodule of 33 mm of diameter that is not visible by a percutaneous ultrasound. Patient is be placed in an oblique position with the right side elevated up to 45 degrees, and the surgeon stands between the legs of the patient. Laparoscopic ultrasound identified the exact position of the lesion. The application of intravenous ultrasound contrast agents during laparoscopic ultrasonography of the liver has been shown to improve nodular characterization in comparison with an enhanced ultrasound. Then, we use the laparoscopic ultrasound to identify the type of vascularization of the lesion or the presence of perilesional vessels. Why is it important to identify tumor vascularization? Local recurrence is a problem of the ablation techniques, in some instances due to the local dissemination by the portal venous route. Systematic subsegmentectomy has been proposed to prevent these problems. A dye injection into the portal branch feeding tumor defined the stained area on the liver surface, which should be resected. On the basis of this principle, we use the microwave antenna to produce a devascularization area centered on the lesion. Microwave antenna is positioned near the tributary vessel of the lesion, and we performed a thermoablation of this area for 3 minutes at 90 watts to induce a selective thrombosis. Then, after the injection of indocyanine green, we can control the devascularization effect of the ablation of the tributary vessel at fluorescence imaging. Finally, after the confirmation of the complete intrahepatic vascular occlusion, we positioned the microwave antenna into the lesion, and we performed a thermoablation with a duration of 7 minutes at 90 watts. After a few minutes, we repeated the ultrasound evaluation with contrast media. Non-enhancement has been visualized both into the lesion and on the surrounding liver parenchyma. The success of the procedure was further confirmed in the post-operative period. Contrast-enhanced ultrasound was performed in third post-operative day showing a complete necrosis area of ablation.